Hi there. This is Tara with a quick content warning before we jump into the episode. We're talking about eating disorders, which includes mentions of suicide. If this is a sensitive topic for you or anyone listening, please take care. Thanks.
Any comment about weight, shape, and body or food? Those got to go away.
Mama bears are coming out.
Yes.
This is On Nutrition, a podcast from Mayo Clinic where we dig into the latest nutrition trends and research to help you understand what's health and what's hype. I'm Tara Schmidt, a registered dietitian with Mayo Clinic in Rochester, Minnesota. This episode, eating disorders. But first, we have a follow-up question on our episode, liver health. You don't need a detox.
Hello, my name is Diana, and I have a follow-up question on the liver detox podcast. You indicated that up to 3 cups of black coffee is a healthy option, but should it be percolated coffee, or can it be instant coffee, and does it have the same effect? Could you please explain which is a better option? Thank you very much, and thank you for all of your help.
Hi, Diana. Thanks for your question. Outside of the sugar bombs that barely resemble coffee, most cups of joe are going to have the good stuff, like 1,000 bioactive compounds that work together to reduce inflammation and stress on our cells, 2 key drivers of liver damage. Your best bet is likely fresh brewed or ground coffee, which delivers high concentrations of antioxidants. Instant coffee can still provide these, though the effects may be slightly less pronounced since it undergoes more processing and is further from the bean itself. If just thinking about 3 cups of coffee gives you heart palpitations, know that research suggests that decaf brings the benefits for the liver too. So cozy up with your favorite mug and your favorite nutrition podcast and feel good about your bean juice. If you have a follow-up question, leave us a voicemail at 507-538-6272, and we'll answer it in a future episode. Now, on to the show. Nearly 31 million Americans will have an eating disorder in their lifetime. But eating disorders are so much more than just bulimia or anorexia. And are GLP-1s causing even more of them? Here to explain is Dr. Angela Mattke, a pediatrician at Mayo Clinic in Rochester, Minnesota. Dr. Mattke specializes in eating disorder treatment and is passionate about supporting patients early on so they have the tools to keep fighting. Hi, Dr. Mattke. Thanks for joining me again on Nutrition.
Thanks for having me back. I'm looking forward to a fun conversation.
I know. I always love talking to you. And this is not a fun topic, but it's an important one. It's important for me as a dietitian. It's important for me as a mom, as a woman. I feel like I've been exposed to all of the nonsense from a very young age, right? Mm-hmm. Are you traumatized by magazine covers that
from the 90s? Yeah. And everything being fat-free. I am. No. And the diet culture still continues to today. So
it's still here, folks.
Yep.
So I think a lot of times when people think of eating disorders or think of someone struggling with an eating disorder, they have this kind of picture in their mind of likely a young, white, affluent woman who is struggling with her body image, which can be true. And while that is absolutely a valid experience, there are other types of people who struggle with this condition that I think can get overlooked sometimes in society and maybe even in the medical field, unfortunately. Can you share some of those populations that, of course, also deal with eating disorders?
I'm so glad you're bringing this up because we only think of the made-for-TV movie, white, affluent,
middle school girl,
cisgender, high-performing type A perfectionist, and emaciated, right? Eating disorders, they don't know race, color, socioeconomic status, gender, anything. I see it every day in my eating disorder clinic. I see patients across the spectrum. I treat so many males, and we think about men not being affected. Wow. And I am a pediatrician, so I'm mostly seeing patients that are less than age 21. But this goes for adults too. Eating disorders happen in the elderly population, Black, Indigenous people of color. They are so much less likely to be recognized, identified, and referred to treatment, and they present much sicker because of of the biases that the healthcare population does have about eating disorders. And honestly, what it comes back to is a lot of the training or the lack of training that we get in those areas too.
Or even research, right? Are they underrepresented in research?
100%. Just like women in general are underrepresented in research, people of color are not represented well in research. And that is hopefully something that we can continue to work on and change.
People with obesity can be suffering from an eating disorder, but it's not obvious to the naked eye.
No, and that's why I said in the beginning, people of all different body types. And the majority of patients that we see referred to our clinic are people either living in bigger bodies or started living in bigger bodies, and that now might be in a normal weight and are being praised for it, but inside they're suffering. And the other thing about eating disorders is that it is a disease that people live with so much shame about and often really struggle to seek help. And it's also an egocentric disease, meaning the disease also doesn't want help. And the disease is going to try and continue to have like full control of that person's body and continue to cause malnutrition and harm for them.
Yeah. And I think one of the hardest things is that the treatment is to nourish yourself, right? Is to restore weight.
Right.
But it's so different than something like having an addiction to alcohol or having an addiction to drugs, which you can wonderfully live your life without, limit your exposure to, never have it in the house. Someone once gave me the example of having an eating disorder or being treated for an eating disorder is like having a tiger as a pet.
Right.
Like you have to walk this tiger. You can't just put it in a cage and be like, oh, that's dangerous. Yeah. You have to like take it to go to the bathroom.
It's everywhere. It affects every single aspect of your life, your day, your interactions, everything. And it's such a fundamental part of being a human that we need to eat, we need to sleep, we need to drink to stay alive. And so I think that's why one of the parts of people feeling shame, but it's like any other disease. It is a disease just like cancer is a disease, asthma is a disease, alcoholism is a disease, depression is a disease. And nobody asks for these diseases and they're not a choice. And it's not just about control. I think sometimes people think about that.
Or wearing a certain size jeans or weighing a certain, that is the eating disorder causing those behaviors. That's not just someone who wants to wear a size 0.
Exactly.
Can we talk about the difference between diagnostically you have an eating disorder versus maybe you have some disordered eating behaviors? Like where does it cross the line? Is it frequency? Is it weight changes?
Yeah, that's a wonderful question because I think a lot of people, and probably most people at some point of their life, may have what we call an intrusive thought that is a disordered eating thought. And it probably gets at, I shouldn't eat this. It's going to make me fat. This is bad for me. Like we put food in dichotomies, good and bad.
I should work this off in the gym.
Yes, and they are pervasive. Anywhere you're at any social event, any conversation, you will hear these kind of comments. Those comments by themselves do not mean that it's an eating disorder. These comments, though, can lay the foundation for an eating disorder, and they're not the cause of it, but these little thoughts and changes can start to spiral. And where it crosses into being eating disorder is, and there's so many different types of eating disorders, but I'm just going to say anorexia. Some people can lose weight. And we see changes in all over our body when we start to lose weight. But for some people, something changes in their brain. We almost call it like a switch is flipped. And all of a sudden, it becomes something that is controlling every aspect of their life and is causing impairment or challenges with weight, shape, and body, with eating, with their relationships, their inability to recognize themselves as being malnourished when they really are and seeing themselves as something different. And so when it becomes something that is causing harm to them, is it affecting their relationships or even just like skipping lunch and stuff like that, that can become really dangerous for some people. And that's where it becomes a disease. And so for anorexia, it's when we start specifically to see weight loss that goes along with this and these kind of behaviors and criteria. We can go through all the DSM criteria, but I'm sure people are not really interested in the little check marks that we look at when we're trying to figure out what type of disease it is. But like you talked about, treatment involves nutrition and it involves nourishing your body. That is the fundamental treatment aspect in
that's
all
the
of
medicine.
Them.
Food is the medicine.
Food is the medicine. And I think that applies to everything in life. Like if we can just think about food being medicine and being nourishment for our body and not a punishment or something we restrict or that we have to compensate for in the gym. Yes, food is medicine, people.
I love it.
Preach.
Are some people more likely to develop an eating disorder because of their genetics?
Genetics definitely plays a role. I mean, we don't have a gene identified, but we certainly see these happen in families that are really intentional about never talking about weight, shape, and body. And something happens with these kids, they lose weight and something flips in their brain.
How much of eating disorder behavior, whether it's diagnosed or just, quote, disordered eating, do you think comes from environment. This is obviously mental health diagnosis, right? That's how it's categorized. But how much of our environment do you think plays a role?
Environment definitely plays a role, but I want to be really cautious when I say environment because I don't want to blame families because families are not the cause of eating disorders. That's like very foundational in family-based treatment and stuff because there's enough shame that goes along with this disorder. We call it being agnostic to the cause because sometimes we know what the cause is. Sometimes the teen was bullied. Sometimes there was a horrible thing that happened in their life, a trauma. Sometimes there were people in their life that were saying things, but it doesn't do us really much good to place blame on them.
It doesn't really help.
It doesn't help. We have to figure out how we move forward and help them. I think there's also society as a whole. I think it does require everyone being accountable for kind of how they look at their own relationship with food and weight to start there first.
As a parent, now I'm like hyper aware of words that others use and comments that females in my family make about their own body, make about the food, make about the cupcake and the cookie. And
oh my gosh,
I snap.
I was
politely
like Mama Bear. I am
people.
Mama Bear. No, I snap sometimes. I remember some relatives making comments about my youngest child's weight and shape when he was a little baby and like a toddler and stuff like that. And I was like, oh, do you want me to start making comments about you? Because it's not appropriate to make comments about my child's weight or shape. It starts now. These are not okay. If you have something to say about my child, talk about their integrity, their grit, talk about their persistence. Let's not talk about what they look like, you know? And he's perfect. And he still is.
Yes, you are. Let's talk about some of the definitions of these eating disorders and their symptoms, because I do think people are most familiar with visually identifying someone who may have anorexia nervosa, or we know what bulimia nervosa is. Can we run through a few of them?
So anorexia nervosa and bulimia are the most common ones, but the one that's actually most commonly diagnosed is something called OSFED, other specified feeding and eating disorder. A lot of people fit into this OSFED, 50% of people coming to eating disorder clinics, because there are really like kind of strict criteria. If you go to this diagnostic manual of diseases that has where we place people in these disorders. And like you said, if you are starting at a higher weight or you've lost weight and you're still really sick, but people can't necessarily articulate or see it from the outside. And so that's like the subtype that doesn't really fit neatly into anyone. And most of the time, treatment is still food is medicine for these people, normalizing routines, giving them support. Anorexia nervosa usually starts with restriction of some type, some intense fear of weight gain or concerns about weight or shape in their body image. And sometimes people don't realize that the patient might not be intentionally saying like, I want to be skinny. Sometimes it's like, I want to be healthy. I want to be fit. Those are the new like politically correct terms to say to be like normalized and accepted in society.
My first thought when you were describing, I'm doing this for health, I want to be healthy, I'm eating clean, etc.
Yes.
I think of orthorexia, which is essentially kind of an obsession with eating healthfully.
I mean, it is, but orthorexia is really something the media has made up because it's not a diagnostic term. It's not anything that doctors actually diagnose. It's not in the DSM criteria. It's only been perpetuated in media. And really is kind of a politically correct way to say anorexia. If you look at orthorexia, it's an intense preoccupation with weight, shape, body, and food intake. And there's very strict management of what you eat and how you look.
We all know these people on the internet. Okay. How do we diagnose binge eating disorder versus I had a lot of ice cream that one night that my high school boyfriend broke up with me?
Yeah, it's going to be a pattern. We always talk about patterns and impairment. So it's eating more than you would regularly eat in a 2-hour period. And it's something that goes on for at least once a week for more than 3 months. Okay. And there's usually no compensatory behaviors with it, meaning like vomiting, using diuretics, over-exercising, those different types of things. So that is what goes on with binge eating disorder. It's actually quite prevalent, especially in the adult population.
And nighttime eating syndrome falls under?
It falls under OSFED, so other specified feeding and eating disorder. It's a type of syndrome, they call it a syndrome, where people eat at least 25% of their daily intake of calories in the evening period, as opposed to binge eating can happen anytime. And so that's how you differentiate between the two of them.
Do you feel like products, and I hate even saying this, like flat belly tea, detox tea, are sometimes contributors to people's disordered eating, or that might start them, or they might end up abusing, things like that.
Absolutely.
We know that laxative abuse is a real thing in
It
eating
is.
disorders.
It's compensatory behavior that we see in anorexia and bulimia and OSFED, all the things. Yeah, corsets. Like there's a lot of things that you just go on Instagram and it's going to be marketed towards you if you're looking at anything. Yeah, I do think they contribute. Like I said, some media is really working really hard. I think there's parts of industry that are definitely perpetuating our diet culture and perpetuating the idea that thin is better than whatever you are. And we know that one body shape is not better than the other body shape, but it's absolutely part of something that is perpetuated.
We also talk about body dysmorphia.
So body dysmorphia disorder usually has nothing to do with like a fear of gaining weight. If they have any fear of gaining weight that goes along with like wanting a thin body image, that's usually falls in with anorexia.
Okay.
Body dysmorphic disorder is like a fixation of kind of one part of your body specifically that is really hard for people. So again, very common in media, and they kind of use it interchangeably with what eating disorder providers would say anorexia. But it's mostly like if there's a scar or a nose that they don't like, or like a stomach or something with their hand or their ear, that's more body dysmorphia disorder, where they're seeing something, perceiving it as something that it not really is. And that's the nausea. When people having eating disorder, not recognizing how thin they really are. And that goes along with it. And sometimes people are struggling within that category as well.
So I'm hearing that a lot of these terms and topics that the media talks about are really falling under the category of anorexia.
Sure are.
But we are not saying that.
Or they're on the spectrum of developing an eating disorder like anorexia. And it's probably really well-intentioned because there's so much stigma with anorexia. Anything that can kind of get the word out that maybe this can be dangerous or harmful to people, I'm fine with, and I don't want to criticize them. But I think just want people listening to hear that if we're calling something orthorexia and it's really causing significant impairment, weight loss, function problems, severe obsession with weight, shape, and body, it's probably anorexia, and the treatment is going to be the treatment for anorexia, and it's going to be food and normalizing and exposing them to things that feel really scary to their brain.
Eating disorders don't just affect one type of person. People across all races, genders, sizes, and socioeconomic statuses can find themselves struggling with food. These mental health conditions usually involve a preoccupation with weight, shape, or body. Sometimes they're genetic, sometimes they're just a product of their environment. The most common diagnosis is Other Specified Feeding and Eating Disorder, or OSFED. OSFED may look like other disorders, like binge eating disorder, anorexia, or bulimia nervosa, but it falls short of meeting the exact criteria for those other disorders. Some examples are excessive nighttime eating or laxative abuse. Regardless of the diagnosis or label, disordered eating can be dangerous. Next, we'll dive into what the research says about the risks. I want to talk about the effects of eating disorders through the research that was done not too far from here. You know, I'm a proud alumni of the University of Minnesota.
Me
Twin
too.
Cities. You
Go
are?
Gophers!
We're not that great at football, but we didn't go there for the football, everyone, okay? Give me a break. I used to teach teenagers in child and adolescent integrated mood program.
Yes.
And I would talk to them about the Minnesota Starvation Study because it, though maybe not ethical, is fascinating. Can we talk about it?
Yes, please. I teach any of my patient about this, and I actually teach patients before they develop an eating disorder. So if I'm seeing them for anxiety and depression, I start because usually they're struggling with eating, because that is the time to teach them how profoundly food is affecting their mood. It happened in 1944, 1945, and it was conducted by the U.S. Army. The study was designed and run by a man named Ansel Keys.
Very important researcher in nutrition.
And they knew people were starving around the world, and they knew the U.S. government was going to be responsible for refeeding the world's population. But we really didn't quite understand how to refeed people effectively, and we didn't necessarily understand all the effects and all the consequences of starvation. So they took volunteers. They were conscientious objectors to war, and they were all men. They were all white men, actually. And college-age and graduate students, they had over 200 apply. They only picked 36 of them because they had to be completely healthy. They had to have no mental health disorders, no physical health disorders. They had to have really high rates of resiliency. So they picked these guys, and they literally lived in the Minnesota football stadium for 12 months. They went to college. They worked during this time, but they took all their meals there. And in the middle 6 months of these 12 months was really the intervention period where they literally starved these guys and then they refed them. And like you mentioned, not ethical. These are not the research that we are doing today, people, okay?
But this is like a groundbreaking study.
It is groundbreaking. The only thing they changed was their calories. They went down to 1,570 calories a day, which actually isn't profound when I look at our caloric intake nowadays, but this was a different society. This was a very physically active walking society. These guys had to walk, like 11, 12 miles a week, lots of different
Probably
requirements.
from West Bank to St. Paul.
No, they did. Have you read some of the accounts of some of them talking about the walking and how they could barely make it and they felt like they were going to pass out? So anyway, we learned a lot about what changes physically in the body with malnutrition. You know, every organ system's affected. So from hair, heart, gut, GI tract, everything's affected. Vital signs are affected. But the things that were most surprising, most of these men developed clinical depression, anxiety, or OCD. They would qualify nowadays. One of them tried to commit suicide. Yes. One of them tried to cut off his hand to get out of the study. And almost all of them developed the characteristics that we see in people that have eating disorders. Even though they weren't eating, they thought about food 24/7. They were reading cookbooks.
They were previously reading Playboy.
Yes.
And they were allowed to.
And all they talked about was food. They were obsessed with food. They really struggled to eat when the refeeding period. So in the refeeding period, they tried to get them back up to their pre-morbid weight, so what they started at, and they really struggled. They had nausea, abdominal pain, bloating. Some of them had to be force-fed. We saw some of them micro-chewing during the period. A lot of things that we see with eating disorder behaviors, drinking a ton of water while they're eating. Some of them even struggling with some weight, shape, and body concerns. And some of the guys said that they continued to struggle their whole life with food. Wow. Yeah. One guy said it affected his entire life and his relationship with eating going forward. And so most of the time, malnutrition and eating disorders are 100%, we can treat them. They are treatable, but the profound effects that we have, that changes in our brain, we see changes in your neurotransmitters. We see changes in your body's ability to have the substrates that you need for serotonin. We see changes in the way that your neural connections are made when we think about weight, shape, and food. And we see changes in your white and gray matter in your brain.
That's the scariest thing in all this, yeah.
And these are reversible with food, okay? I think there is a light at the end of the tunnel, but when people are struggling with depression and anxiety, sometimes it's chicken or egg, which came first, the depression, anxiety, or the eating disorder, and people can back themselves into eating disorders because they're not eating very well, right? Yeah. Like we talked about, something flips in some people's brains. So if people are struggling, one of the best things they can do is making sure they're getting regular meals and snacks if they're having depression and anxiety, because that is the food for their brain that's going to be the substrate of helping them get better. Starving brains are anxious brains, people.
I want to get into eating disorders and truly the health risks related to them.
Yeah.
Do eating disorders have the highest mortality rate when we talk about mental health disorders?
They're second, actually, to opioid addiction. And there's varying rates on mortality associated with eating disorders. But with anorexia, the mortality rates can go up to around 20% of dying from your disease in your lifetime. Because I did not know this as a doctor for many years. I wasn't taught this in medical school or anything about how serious these are. Yeah. And we think of them as just like, oh, it's just control. They're doing it to themselves, right? We hear like this being perpetuated all the time in media. But is it a disease? It is not something they're choosing, and it has incredibly high rates of mortality. So I'll explain to my patients, and I'll compare it actually to childhood cancer. So if we look at, most people have heard of leukemia, specifically ALL. It's one of the most common childhood cancers that we see. 5 years out from their diagnosis, they have improved survival rates dramatically. It's 5 to 10% mortality 5 years out. But if we look at anorexia in their lifetime, it's up to 20%. That's 1 in 5 people may die from complications related to their disease. Sometimes it's malnutrition. Sometimes it's heart failure, liver failure, electrolyte problems. Sometimes it's suicide. So the thing we haven't touched on quite yet is how profoundly eating disorders and malnutrition affects your mental health.
Yes.
Most of these patients are going to look very depressed, incredibly anxious, maybe OCD as well. And if you are in that state of malnutrition, your neurotransmitters have changed, the neural connections in your brain have changed. We can see this. The white and gray matter in your brain have changed on MRI. It is not surprising to me that you are going to be more likely to have suicidal thoughts. And I see this all the time in my patients that are suffering.
So I also want to touch on GLP-1s, which sounds off topic because those are used to treat obesity and or diabetes. But I think we're also seeing, unfortunately, them being used by people who are either maybe developing an eating disorder with their use of a GLP-1
Absolutely.
or people perhaps who have an eating disorder getting access to them.
Right. Yeah. I think we're seeing, and I've seen this a lot in my clinic, actually, pediatric patients or young adults being started on GLP-1s and either one of two things, unmasking an eating disorder that was probably there.
Okay.
We see eating disorders morph. Sometimes they can be binge eating disorder that can morph into anorexia nervosa. As soon as you start developing that weight loss, something's going to flip in the brain. We're also seeing patients who maybe didn't have an eating disorder prior to being on these. With the weight loss, it literally changes the chemical structure, function, and neurotransmitters in your brain, unmasking and developing a significant eating disorder.
Wow.
And I think these medications are great in the right hands. It's a huge topic of debate amongst eating disorder providers, especially if a person previously had an eating disorder and they are in recovery, would we ever consider putting them on a GLP-1? That's why monitoring is so important in these medications. You need to screen at the beginning, but you also need to be constantly screening and making sure that things are not a concern. And we're seeing so much rapid muscle loss with these medications. So we need to make sure that people are also getting exercise and doing weight-bearing exercise and lifting with these to make sure that they are maintaining their mass, because when you lose weight, it is not selective. I hear it every single day in my clinic from parents. They'll try to reassure to their child that, don't worry, you're only going to lose fat and you're going to keep your muscle. I was like, that's not how it works.
If we had figured that out by now, we would be using it.
Your body will lose both.
And a little bit of bone and some water.
Yes.
Now, we're using GLP-1s, though, correct me if I'm wrong, to also treat binge eating disorder, which does fall under an eating disorder.
Yeah.
So it's complicated.
I think we're using it only in adults for that I'm
believe
aware
you're
of.
right. Yes.
And not my experience in peds are we doing that yet, but I would like to see the long-term data on that and see how things go and make sure that we're not flipping, like I said, how eating disorders morph and they're tricky from one eating disorder into a different eating disorder.
A lot of what we know about the impacts of eating disorders comes from the Minnesota Starvation Study. This research done on young men in the 1940s showed that eating disorders can harm every organ system and trigger conditions like depression, anxiety, or OCD. These mental health impacts can last a lifetime. It's hard to tell which comes first, the mental health condition or the eating disorder. We're discovering that a GLP-1 can actually reveal an eating disorder, morph into one, or even be used to treat them, specifically binge eating disorder. These conditions are clearly complicated, and they can be deadly, which is why treatment is so crucial. We'll talk about that next. Let's talk about how we go about finding support. Where do we start?
Start with someone, because the majority of people see no one. Okay, the majority of people don't see their mental health provider. Majority of people don't see their primary care provider. So start with one of them and someone can help. I'm a medical provider, so I say come to us because there can be medical complications from weight loss and eating disorders that are really severe, and they can help evaluate for that. They can do labs, they can do ECG, vital signs, all the things to make sure that you're stable enough to work with a mental health provider or an eating disorder provider as an outpatient and not have to go to a higher level of care like an inpatient facility or a residential facility where there's more active monitoring to make sure you're not going to have complications. So let them know that you're struggling. And if they don't know where to send you, they should ask somebody. And if they don't know, then there are national resources, there are national websites that you can go to. You can even self-refer to. So if your provider doesn't know, because honestly, like I said, we get very little training, it's okay to be an advocate for yourself too.
You mentioned outpatient treatment and inpatient options. What do those look like?
So the lowest level of care, meaning like it's going to have less support for the person who's struggling, is going to be outpatient. Most of the time, it's going to be a mental health professional. It's usually weekly, maybe twice weekly if you're lucky. And a lot of times it doesn't involve other members of your care team. It's usually just maybe one care team provider. If you're lucky, maybe a couple. There might be like a dietitian involved or maybe a psychologist and stuff. And that works really good if we catch your disease early. So the earlier we catch your disease, the better the outcomes. Most people have a year or more before they are identified and referred to treatment.
That's a long time.
It is a long time, and get them in right away. Before it's anorexia. Do it when it's OSFED, before it's really serious. Then the next level is going to be something called intensive outpatient or IOP. These are usually 3 to 4 hours a day and usually 3 to 5 days a week. And that is going to have a multidisciplinary team, usually a dietitian, a mental health provider, some type of physician representative, as well, sometimes a social worker. And they're going to be giving you eating disorder treatment from all different aspects and helping support you. The next level up is what we call a partial hospitalization program. I don't understand why the word hospital is in it, because most of the time it's never in a hospital, it's more in an outpatient facility. But that's usually going to be all day, like an 8 to 5 sort of program, or you'll have most of your meals there, but you'll go home and sleep in your bed at night.
Got it. What if a case is a bit more severe?
The next step up is a residential treatment program, and that's where you go and you stay until they feel that you're ready to step down, usually to an outpatient setting. So it's usually a stepwise peeling off the layers of support a little bit at a time if you have to go to residential. The highest level of care is the hospital, where they can keep you on cardiopulmonary monitoring, so they can look at your heart rate and your blood pressure. They can check your glucose, because glucoses are notoriously low because of abnormal glycogen supplies, abnormal insulin responses. But you also can have electrolyte abnormalities. Yes. You can have serious cardiac arrhythmias. And so patients are usually only in the hospital while they're medically unstable, because it's hard to really get much treatment going at that point, and then they step down.
We know that a significant portion of patients with eating disorders will unfortunately relapse.
Yeah.
So how do we set ourselves or our family members up for success after treatment?
So the highest rate of relapse is going to be in the first year. And the highest rate of relapse is people that don't finish treatment. There's a pretty high rates of people dropping out of treatment, because this is one of the hardest things you'll ever do. For most people, it is probably the hardest thing that they will ever encounter. For parents, they rate it as high as or higher distress that they have as having a child going through cancer treatment. So if you can support your loved one to get treatment and finish treatment, that's going to set them up for success. And then making sure they have close follow-up afterwards, and also making sure that we're setting the environment up that they're coming back into to being supportive for their emotional needs, supporting them with eating. So that includes any comment about weight, shape, and body, or food comments even, those got to go away.
Mama bears are coming out.
Yes. So all foods are healthy foods in moderation, and especially in eating disorder treatment and recovery. And so eating with them and eating what they're eating is going to be incredibly helpful. If you're sitting there dieting and talking about your diet, especially an adult, you're sitting in your lunchroom and you're talking about, oh, I'm on a diet, and this person is in recovery, it's incredibly triggering for them.
Of course.
And then also just periods of high stress in their life. So anytime you're going to have a transition in life, a marriage, a graduation,
college,
a new job, college, birth, pregnancy, those can be really high times of relapse. So supporting them and giving them extra support with their nutrition during that time can be immensely helpful.
And when you talk about relapse, I also think of kind of the analogy of someone who has had alcoholism, which is a disease.
Yep.
They kind of say,
you're always in recovery.
Yes. Mm-hmm. Is this also true for eating disorders?
100%.
Okay.
100%. Relapse can come out of the blue at any time in your life, and you can't ever let your guard down. So I teach my patients, when I create their relapse prevention plans with them, is really never letting your guard down. They're not somebody that can just go and skip meals willy-nilly. No. They have to be proactive.
Just like you can't go to a bar willy-nilly if you have a history of alcoholism.
Exactly. You have to plan ahead. You have to be thinking about what environment you're putting yourself in and how you're going to make sure you get your medicine in each day. Because it really is their doses of medicine for the rest of their life that they're going to be taking, which is food.
Oh, that's so meaningful. What's your advice for listeners who feel like they may have a loved one or a friend exhibit some of the behaviors that you've described? How do we encourage someone if we think they might need help?
It's harder when they're an adult. I think bringing their concerns to them in a non-judgmental and supportive way and focusing on their health and their safety can be helpful. Don't be surprised if they're defensive or they don't hear you or they deny it. It's continuing to show up and be there and encouraging them and eating with them and buying food and having extra food around and not talking about weight, shape, and body around them, because sometimes it's going to take an adult a little bit longer to get there and be ready for treatment. And you can be there to support them in the steps and nudging them along the way, but not letting it go. It's not one and done. It's letting them know that you're still there for them and you're concerned and you're there for them when they're ready to take the step to get the treatment and support that they need.
So staying present.
Staying present, eating, supporting.
Any last tips that you have for people who want to heal their relationship to food? And I would say this goes for people with or without a history of.
Yeah, we
all have wonky relationships.
We all have wonky. Everyone has something, or at one point had something weird going on. I really like intuitive eating.
I love it.
And I really do think that for patients in eating disorder recovery and without, intuitive eating is going to be the way to set our patients up who have struggled. And for people that haven't struggled, it reexamines our entire relationship with food.
Yeah. Dr. Mattke, thank you for coming on On Nutrition. You are absolutely wonderful. We're so thankful for all of your knowledge and what you do.
Thank you so much for highlighting this important topic and bringing it out of the shadows. So it means a lot.
There are levels to treatment for an eating disorder, ranging from therapy to hospitalization. What's important is that if you're struggling, you seek out help. It's normal to relapse after treatment, but if you or a loved one are dealing with an eating disorder, don't give up. Support and recovery are a lifelong practice. If you need to talk to a professional for help, you can also reach out to the National Alliance for Eating Disorders at 866-662-1235. That's all for this episode, but if you have a follow-up question, leave us a voicemail at 507-538-6272, and we'll answer it in a future episode. For more On Nutrition episodes and resources, check us out online at mayoclinic.org/onnutrition. And if you found this show helpful, please subscribe and make sure to rate and review us on Apple Podcasts or your favorite podcast app. It really helps others find our show. Thanks for listening. And until next time, eat well and be well.